Hello, everyone, and welcome to the latest edition of the Journal Club at Arrhythmia Academy, where we're going to discuss some very exciting latest developments in the treatment of VT storm. In particular, we're going to discuss two papers that were published recently in the journal Europace. I'm Dhiraj Gupta, electrophysiologist at Liverpool in the United Kingdom, and it gives me great pleasure today to be joined by eminent speakers from Italy, Professor Della Bella from San Raffaele Hospital in Milan, Dr. Simone Savastano, and Dr. Enrique Baldi from Pavia, again in Italy as well. So welcome to all of you.
Thank you so much.
So the ones.
Thank you.
So for those of you who are not quite used to the format of the Journal Club, we will kick off with presentations from the speakers about their the journals and the articles that they've published. And then we'll have a very brief, 10 to 15 minute focus discussion on the content of these papers, in which we will put these in context with all the evidence which is out there. We'll give you some take-home messages at the end. So we're going to start with Professor Della Bella. He's going to talk about just a broad overview of the treatment of VT storm and the information that we have and the evidence base that exists at the moment. Professor Della Bella.
Dr. Gupta, dear ladies and gentlemen, very, very proud to be part of this interesting journal club. My talk will be dealing on the treatment of VT storm, try to overview the topic. Electrical storm is defined as the occurrence of 3 or more episodes of VTVF over 24 hours, and it has been reported in up to 20% of the patients in secondary prevention. It actually is a life-threatening event, and it is identified as a risk factor for cardiac death, heart transplantation, and hospitalization for heart failure. It actually is an acute clinical emergency, and its management should include rhythm stabilization, either pharmacologically or non-pharmacologically, and hemodynamic support to be able to carry out the patient from the acute phase. The role of the cardiac support in maintaining survival possibilities in this patient is stressed in this paper that has published a few years ago, reviewing the outcome of 26 patients that were admitted for intractable refractory arrhythmia storm and cardiogenic shock despite optimal medical therapy. Immediately after extracorporeal circulation, rhythm stabilization was achieved in 61% of these patients, and it occurred invariably in almost all within the next 3 hours. Within the 4 days, however, 13 patients, that is 50% of the patient population, died, and the remaining one were weaned after 6 days from the ECMO and were discharged after 34 days. So the important message of this paper is that the arrhythmia presentation and the arrhythmia pattern ongoing strongly dictates the prognosis. Patients that had intermittent VTVF alternated with sinus rhythm had, as you can see, a much higher likelihood of survival as compared to those that had in a continuous refractory VTVF. It seems, therefore, that achieving a proper rhythm stabilization is one of the main goals in the setting of the arrhythmia storm. Actually, early experience provided by our own experience suggests that catheter ablation in patients that are refractory to the pharmacological treatment is the treatment of choice. As you can see here in this paper that has been published more than 10 years ago, outcome of ablation was defined as class A if no arrhythmias were no longer inducible, class B if the presenting arrhythmias were suppressed but other were inducible, and class C full failure. Failure accounted for 10% of the patient population, and you can see in the right lower panel that the rate of recurrence of ventricular tachycardia over the next 4 years was significantly lower in patients where a full success was achieved, as opposed to those with the intermediate success and those that had a complete failure. This reflected on the possibilities of survival. As you can see, that survival free from any type of cardiac death was much more favorable in patients that had arrhythmia control following the procedure of ablation. So again, this early experience suggests that in patients that fail pharmacological treatment, catheter ablation may play a protective role over the long term, and also together with pharmacological therapy may favorably affect cardiac mortality. These data were echoed by a similar publication offered 10 years later by the IVTCC, the International VT Cooperative Center, that actually gathered data provided by 12 centers around the world involving the treatment of VTs. Out of almost 2,000 cases, 677 were patients that underwent VT ablation because of electrical storm. And they actually, as you can see on the left, had a poorer survival. But the paper shows that patients that had, after the ablation, prevention of inducibility had a much higher survival rate as compared to those that suffer from non-clinical VTs, and of course, those that had persistent VTs or those that could not be tested had a worse outcome. So electrical storm still remaining as a multivariate analysis as a predictor of non-hospital mortality and subsequent death, showed, however, that patients in whom the arrhythmia pattern could be controlled had a much favorable follow-up. Now, digging a little bit in depth the clinical features of this patient, we see that this data clearly open what probably will be our discussion. Treatment of electrical storm is not just a business of the electrophysiologist. Treatment of the comorbidities and the advanced state of heart failure is pivotal in these cases. As you see here, patients suffering from electrical storm had a lower ejection fraction, had a higher incidence of class 3-4 New York Association class, functional class, higher incidence of CRP, and also, very importantly, a higher incidence of comorbidities, including coronary artery disease, diabetes, chronic kidney disease. And that, of course, reflects into the need of providing advanced support through a multidisciplinary approach. The problem here is then how are we able to bridge the patients out from the severe episode of electrical storm. Hemodynamic support is obviously very important. And as we will see in the next slides, emergency hemodynamic support is not really able to provide the full benefit. The question is how to select patients at risk for severe hemodynamic impairment. A few years ago, we devised a predictive score for identifying patients at higher profiles of risk of survival, in whom probably hemodynamic support could be beneficial. And you can see here that all, of course, patients with ejection fraction lower than 30, patients that had suffered from electrical storm, elderly patients that have a CRT on board that is a surrogate of class 3 and 4, are patients that probably more likely will benefit the institution of elective hemodynamic support. The worst quality of the patient actually that had undergone hemodynamic support is reflected on this paper that reflects our earlier experience. At the time, we had 850 patients treated for ablation, and out of these, 62 underwent hemodynamic support ablation for ventricular tachycardia. Again, here you can see that the patients that were supported had a significantly lower ejection fraction, invariably suffer from non-tolerated VTs, much higher incidence of cardiogenic shock and electrical storm. In spite of that, however, the ability of having patients non-inducible after the procedure provided a significant advantage, as you can see here, in terms of lower recurrences of both ventricular tachycardias and of increased chances of survival. Patients that were fully non-inducible actually had a lower incidence of cardiac death, incidence of VET or heart transplant, as opposed to those that were still fully inducible or those in whom the procedure was carried out in an emergency situation. The question now is VAD. Percutaneous support. Is it a device to be placed on a rescue basis? Is it has to be placed on a preemptive approach? This paper published by Dr. Mathuria compares the outcome of patients where the ablation was performed without percutaneous support to those in whom the procedure was supported either on an emergency basis or with a preemptive maneuver. The selection of the patient was based on clinical criteria and also on the inability to sustain a high rate ventricular pacing. Patients that had the procedure non-supported were actually having a much lower incidence of severe hypotension, and as opposed to those that had both rescue or preemptive VAD. You see, however, that in spite of a very similar rate of recurrences, mortality was significantly higher at 30 days among patients who underwent the procedure in an emergency situation. So to say, proper planning of the hemodynamic support plays a pivotal role in carrying the patient over the next days after the procedure. A similar message was conveyed by the sub-analysis of the experience of the PEN group. They provided a comparative analysis of 75 patients undergoing catheter ablation of scar-related VT in whom a prophylactic support was utilized, as compared to those in whom there was no hemodynamic support. The patient population was matched for a high-risk evaluation with a PEN score. So the two groups were comparable, and you see that in spite of a very similar rate of recurrence after ablation over the next year, rate of death and heart transplant was significantly higher among those in whom the procedure was carried out without support. So that means, again, it's that probably being able to identify a priori patients in need for a support is an helpful tool to bridge them out from a severe situation. These data are reflected in the current recommendation of the ERA HRS societies. You see here that the degree of recommendation, class recommendation 1, actually supports the choice of a multidisciplinary approach for the selection of patients that are at high risk and that actually might require hemodynamic support, not only to perform the procedure, but really to be able to bridge them out before, during, and after the phase in the setting of an electrical storm. Also, hemodynamic support with the percutaneous system of VAD or ECMO during ablation can be used to really avoid the severe hemodynamic derangements in this situation. Whereas you see 2B, the indication to use the hemodynamic support just to bridge the patient and to carry out the ablation of hemodynamic untolerated VTs have a lower class of recommendation, because actually there are no data supporting the use of hemodynamic support just to drive the ablation of a bad VT. Just to provide you the flavor of the situation, the clinical situation that we are dealing with, I would like to offer you the clinical history of a patient whom we recently treated. A 62-year-old gentleman that suffered in January of an acute extensive anterior infarct had a very unstable situation, driving the choice to an emergency cabbage in February. The operation didn't go very well. The patient had cardiogenic shock, had to be supported intraoperatively with levosimentan, and cardiopulmonary bypass was weaned with adrenaline and intra-aortic balloon pump. The subsequent course, however, was characterized by very frequent postoperative VT-VF, that leading again to a choice of a repeat coronary evaluation, again coronary angiograms. In that situation, the procedure was complicated by dissection of the proximal circumflex. The patient was anyhow successfully treated, but after the procedure, persistent episode of non-tolerated VTs, VF, occurred, and he was sent to our hospital for management, multidisciplinary management of his electrical storm. At the admission, an impeller 2.5 was positioned in this patient. Initially, he had a trigeminal rhythm with frequent PVCs that were triggering, as you see, episode of VTVF. I tried to resist because I think that the opportunity offering an ablation is much better if the storm is cooled. But over the days, he went on into a refractory episode of VTVF, as you can see here. Episode of VF triggered by PVCs, episode of monomorphic ventricular tachycardia, until the impeller was removed and the ECMO was initiated, bringing the patient to an emergency ablation the day after. When the patient entered the EP room at the beginning of the procedure, he was then in stable sinus rhythm owing to the infusion of lidocaine. There were no PVCs. In this situation, ideally, sinus rhythm mapping and modification could be offered as a safe and effective ablation strategy. But as soon as we enter the catheter into the left ventricle, multiple episodes of untolerated VTs occurred, refractory to attempts of overdriving and requiring multiple shots. We ultimately took the decision to perform the procedure during ongoing VT, also because the presence of the ECMO offered some kind of hemodynamic stability. I think that it is worth here spending 1 second on the ways that we like to perform our activation mapping during VT. As you see here, we like to open a window of interest only during the diastolic phase between the termination of the first QRS and the beginning of the second. And everything that is recorded during each of the phases is color-coded. So everything that is portrayed in white or purple is an electrical event that is related to the QRS. Diastolic phase is divided in 3 parts: entry events, red and orange; mid-diastole, yellow, green; exit, light blue and dark blue. As you see here, there is a wide area of entrance. So you see the area where electrical events are red color coded is quite wide. And that opens to the area of mid-diastolic activity and eventually to the exit. So we are dealing here with a complex circuit with a very wide entrance and exit. And we understood that that would have been a very long day. Actually, you can see here the propagation pattern of the VT, where you can see on this animation a very wide area of entrance followed by a very wide area of mid-diastole. Actually, it took us more than 1 hour of ablation before being able to perceive the first signs of arrhythmia slowing, rhythm normalization, eventually leading to a much slower and easily manageable right-sided VT that at the end could be terminated, as you see here. And the overlapping figure of both the right and the left ventricle leads you to the perception of how deep was the subject of this septal infarct. At the end, the rhythm was stable. The patient was weaned from the ECMO after 4 days. Persistent rhythm stability for 2 weeks in spite of the absence of antiarrhythmic drugs until the ICD-CRT-D was implanted. I think that it shows that really electrical storm is a clinical emergency that requires prompt treatment, primarily aiming at sinus rhythm restoration, quite frequently requiring hemodynamic support. Ablation is effective to reduce arrhythmia recurrences and actually improving survival. Risk stratification according to clinical characteristics of the patient and through hemodynamic tolerance is useful to identify patients that are eligible to preemptive ECMO support and ablation. This allows frequently activation mapping of unstable VTs with extensive ablation patterns in high-risk patients, and the possibility of having a sustained hemodynamic support for days reduces the risk of acute heart failure and death related to the ablation itself and to prolonged periods of general anesthesia. Doors then are wide open to advance non-pharmacological means of treatment like a VAD or hand transplant to provide a comprehensive treatment of advanced heart failure and improve, of course, survival in these cases. Thank you for your attention.
Thank you, Dr. Della Bella. That was exceptional. A very, very good summary of where we are in terms of VT ablation. And thanks very much for sharing that very difficult case. And it showed beautifully how mechanical circulatory support really allowed you to plan the procedure and how you went step by step to go to slower and slower VT till the patient had a good result. So congratulations for that patient. In fact, congratulations for the excellent program that you have that is so internationally well known. Well, we'll obviously discuss this in a bit more detail afterwards, but it now gives me great pleasure to invite Dr. Simone Savastano to talk about this very exciting new technique of left stellate ganglion block for the treatment of refractory electrical storm. So, Dr. Savastano.
Thank you very much indeed for your kind invitation and for the opportunity to share with you some thoughts about the percutaneous left stellate ganglion block for occurrence of ventricular arrhythmias, and in particular some thoughts about the why, where, and how to perform this technique. So let's begin with why. There is a lot of reason because left stellate ganglion block can be useful and helpful in such a difficult situation. For patients in cardiac arrest, we have absolutely to reduce the number of defibrillations and to reduce the risk of cardiac dysfunction after ROSC. We know that the cardiac dysfunction after ROSC is strictly correlated with the number of defibrillation and the energy of electrical shock that has been administered during resuscitation. For what concerns ICD recipients, we have to reduce the number of ICD intervention, and in particular of ICD shocks, because it has well demonstrated that the higher is the number of ICD shocks, the lower is the survival of the patients. Then we have to stop a deadly vicious circle, and I will spend some word about this deadly vicious circle a bit later. Then we have to think about percutaneous left stellate ganglion block, because drugs and non-pharmacological treatments are few and not always immediately effective or available, even in emergency situations. And then because the sympathetic nervous system plays an important role in arrhythmogenic. And then, last but not least, because it works and it works safely. So what I mean for deadly vicious circle is this circle here. If we have many recurrences of VTAC or VFib, we have, of course, a reduction of cardiac output and a reduction of blood pressure. So we have an activation of the sympathetic system and a norepinephrine release at the level of myocardium. And this norepinephrine release is absolutely important because it enhances the number of VT and VF recurrences. And so we have a really deadly vicious circle that can be stopped by a very simple maneuver, that is the percutaneous left stellate ganglion block, as we will discuss later. Then I would like to spend some words about the sympathetic nervous system. We know that the heart is innervated by the left stellate ganglion and the right stellate ganglion, and by the thoracic ganglia. The sympathetic nervous system is able to modify the myocardial conduction velocity, to modify the myocardial refractory periods, and to enhance automatism. And moreover, in case of scars, an unbalanced innervation could cause an inhomogeneous innervation predisposing for re-entry and arrhythmias. As you can see here in this nice paper, in case of left stellate ganglion stimulation, we have a reduction of the activation recovery interval, mostly in the left ventricle. Here, as compared to normal condition, to basal condition, the stimulation of the right ganglion cause a reduction of the ventilation refractory interval, mostly in the right ventricle. Similar results have been reached in this paper, where they demonstrated a huge increase of variance of refractory interval by stimulating the left stellate ganglion block. And that's why we choose to perform only left stellate ganglion block. Finally, in this animal model, during left stellate ganglion stimulation and right stellate ganglion stimulation, they observed an increase of norepinephrine concentration at the myocardial level. And they also noticed that during left stellate ganglion stimulation, the occurrence of VF was more likely. The last point of why is because it works, and it works safely. This is the systematic review published some years ago about 38 patients from 23 studies, and they showed that the left stellate ganglion block was able to dramatically reduce the number of arrhythmic episodes and of shock delivery. This is a more recent study from the Mayo Clinic about 30 cases. And in 15 cases, they performed only the left percutaneous left stellate ganglion block. And in 50 cases, also the right percutaneous stellate ganglion block was performed. They used only a fluoro or echo-guided approach. None case was done during CPR, and no complications have been described. Also in this paper, you can notice the huge reduction of the arrhythmic relapses, comparing before versus after the procedure, and also a great reduction of the defibrillation shocks was documented, comparing before versus after the procedure. These are our results. We published very recently on Europace about 11 patients for a total of 18 procedures. We performed only left stellate ganglion block. No fluoro or echo-guided approach was used, even if the echo-guided approach was also allowed for the study, but the operators chosen only for the anatomical approach. All the procedures were done only by cardiologists, and even in some cases was done also during CPR. And even in our case series, no complications have been documented. We performed two kinds of analysis, one per procedure analysis, comparing 1 hour before the procedure versus 1 hour after the procedures. And we demonstrated a very, very significant, strongly significant reduction of arrhythmic relapses. Then we performed a per patient analysis by comparing the 24 hours before the procedures and versus the 24 hours after the procedures. Also in this case, we showed a very, very significantly reduction of arrhythmic episodes. So where is the left stellate ganglion? This is our neck. We can remove the platysma muscles, and we can find the sternocleidomastoid muscles. We can remove it, and we can find the vessels, the internal jugular vein and the carotid artery, and the 3 scalene muscles, the anterior scalene muscle, the mid scalene muscles, and the posterior scalene muscle. So if we remove the vessels and the anterior scalene muscle, we can see the left stellate ganglion there, very deep in the neck, near the column. From a lateral point of view, we can recognize the internal jugular vein and the anterior scalene muscle. If we remove the trapezius muscle and the scalene muscles, we can find the sympathetic chain here deeply in the neck. So how can we reach this region, and how we can perform the technique? Basically, we have 2 approaches, and the one we preferred in our paper was the frontal anatomical approach. So this is the neck of our patient. We can identify the anatomical structures, in particular the sternum and the cricoid cartilage. And so by identifying the sternum, we can move 2 centimeters above the sternum and 2 centimeters leftward. And this is our target zone. So the first operator with his hands, with his fingers, can move laterally the sternocleidomastoid and go deeply inside the neck up to the bones. So with the frontal anatomical approach, the needle is inserted anteriorly from the front to the back up to the bones. Then the needle is retracted some millimeters. And then, after an aspiration check, the anesthetic is injected in the target zone. Some considerations about this approach. The first consideration is that very little equipment is needed, only a syringe and a needle and a skilled operator. The second consideration is that by moving leftward the sternocleidomastoid muscles and the vessels, the risk of vascular damage is very, very low. The third consideration is that by feeling the bone beneath the finger of the operator, the space is very, very little, so the risk of complication is very rare. And the last consideration is that the bone represents an anatomical stop, so it prevents the operator to go too deep inside the neck. So the needle will stop here at the level of the bone. This is a real case, so we can recognize the anatomical structures. So the sternum, 2 centimeters above the sternum and 2 centimeters leftward. So here is our target zone. So we insert the needle, and the second operator, while the first operator is holding the needle in the neck, the second operator is slowly injecting the anesthetic. In this case, we use only lidocaine, 200 milligrams. So very slowly, after aspiration check, the anesthetic is injected in the neck. This kind of approach is also useful for continuous infusion. For continuous infusion, we use a epidural kit consisting in a catheter, a syringe, and a particular needle. In any case, for anatomical continuous infusion, we insert the needle in the same way I showed before, but this needle has a particular orientation of the tip. The tip of this needle is laterally oriented, so we have to be careful to insert the needle and to orient the needle tip downward in order to put the anesthetic toward the ganglia. Then, after the injection of the anesthetic, so after the bolus, we can insert inside the needle the catheter, and when you feel some resistance, you remove the needle while holding the catheter inside. And then you connect the catheter to a syringe for a continuous infusion. Then we have a lateral echo-guided approach. So the target zone is here, as you can see, as you saw before. But in this kind of approach, the needle is inserted through the anterior scalene muscles, reaching the target zone here. For this kind of technique is of extreme importance the knowledge of echo anatomy. So we have to identify the structures. So the carotid artery and internal jugular vein. Then here we have the vertebral bone. This is the longus colli. This is the anterior scalene muscle. Here I have the esophagus, and here we have the target zone. So the needle has to be introduced through the anterior scalene muscles above the longus colli, beneath the carotid artery, in the target zone. You can see here a live procedure. So you can identify the tip of the needle and the anesthetic reaching the target zone. So some considerations about the lateral echo-guided approach. The very first consideration that is quite important is that ganglia are not visible at echo. So echo is not useful to identify the correct location of ganglion, but it's useful to follow the tip of the needle along the procedure in order to avoid damage and complication. You need very skilled operators, not only in percutaneous stellate ganglion block, but also in performing echo-guided procedures, because it's not quite easy to be really sure to identify the tip of the needle along all the procedure. Mostly in some cases, let's imagine a patient during cardiopulmonary resuscitation with chest compression ongoing. So it's not quite easy to be extremely sure to be able to identify the tip of the needle. Then the space that the needle has to pass through is very thicker than before. In the anterior approach, the space was very thin. In this case, this space is thicker. So there are more anatomical structure, and so the risk of complication could be higher. And then in the lateral approach, we have to be very careful not to damage the brachial plexus that is here. That's why our operators have chosen the anterior anatomical based approach, because it's easier, and in my perspective, it's less risky. So complications are very rare. The most frequent, even if they are rare, are neurological symptoms due to local anesthetic absorption, and that's why you have to be ready to lipid rescue, such as that is to say to inject some lipid to antagonize, to contrast the effect of the local anesthetic in vein. Then we have intravascular injection, but it's preventable because we always perform an aspiration check before injecting. Then we could have vascular damage at the carotid or vertebral artery level, or even at the small vessel level. And then finally, nerve damage or anesthesia. We have one case of reversible brachial plexus anesthesia. So in conclusions, we can absolutely say that percutaneous left stellate ganglion block is a valid option for patients with electrical storm. It's effective, it's safe, and it could be performed without any additional equipment by trained cardiologists. And I thank you very much for your kind attention.
Thank you, Dr. Savastano. That was exceptional. I love the way you brought the anatomy of the region, the very complex anatomy of the region, to life through your slides and also through the video as well. I'm sure Professor Della Bella would have enjoyed that presentation as well. I'm delighted that we've got Dr. Enrico Boldi as well, one of your colleagues from Pavia. So we'll have a brief discussion about this technique and where it sits amongst the armamentarium of the other tools that we have for treatment of this very difficult patients. First of all, I'd like to ask you, there's obviously lots of very important anatomical structures in the vicinity of the left stellate ganglion, the carotid artery, the veins, etc. Why not bring the best of both worlds? Go anteriorly, but use ultrasound to guide your access, and to use ultrasound to tell you where the carotid artery and the vein exist.
To be honest, the very first procedure has been performed with an anterior approach by somehow guided with echo. But I prefer not to use echo, first because I'm not so skilled in this particular kind of procedures, and then because if you move laterally the sternocleidomastoid in an awake patient, you feel the carotid artery pulsing beneath your fingers, so you know exactly where the carotid artery is, even without echo.
Sure. And what was your learning curve for this technique? I mean, it seems very complex, but then most things are very complex if you start doing them. So what do you say? It's 5 cases, 10 cases? Did you go anywhere to get the training, or did you train on yourself? Did you try cadavers first? I mean, I'm sure our listeners and viewers will be interested because obviously this is such a novel technique.
There you go.
Yeah, so the training is very important. And for this reason, we have prepared a course, a training course for the cardiologists or intensivists who want to learn this technique. The curve is not so high, so there is not a need to perform 20, 30 procedures before being skilled. But obviously, the training is important also because we have created a simulator using our three-dimensional print in our polyclinic foundation. And so the cardiologist has the opportunity to learn about the anatomy, to learn about how to insert the needle, both in the echo-guided technique and in the anatomical-based technique. And we believe that this type of training is very important, at least for the first step. Our experience is that our colleagues prefer to have our support of Simone or my support for the first 3-4 procedure, and then they are skilled to perform by their side.
So Dr. Della Bella, do you have any experience, or anyone in your center has any experience with this? And what do you think about where it sits amongst the decision-making process for patients with electrical storm?
Again, let me tell you, I found this is fantastic. I liked it a lot. I enjoyed it and really wish to congratulate the two colleagues for their proposal. I think the apparent simplicity puts this technique in first line. Simplicity because probably they know how to do it very well. So I think the training is critical and of primary importance. I was actually, while listening to this very nice talk, thinking to our patient, that the one that I have described, and really I think that it should really sit among the actions to be undertaken by the intensivist. Usually patients with severe arrhythmia storm are into the setting of an intensive care, so that I think that people working in intensive care should be trained. I think it should be really performed. What do we perform to achieve neural control? Actually, anesthesia, epidural infusion of anesthetics, but of course it is much less selective, and therefore it really seems to be quite brutal as opposed to this very elegant approach. So I think it really, your work should receive a wide echo and a wide attention. I really would like to get the way to get in touch with you guys, because really, of course, whatever we do, hemodynamic support, ablation, it of course has a kind of a longer range, but we need really to take the guy cool now. So really, the idea of being able, I mean, this guy that I have treated just to stay on clinical grounds, and I think it's beautiful. The guy has suffered for 10 days of shocks, general anesthesia, hemodynamic support, and of course the situation was a very tough one. Of course, probably temporary cooling of his arrhythmias may just have helped in getting probably the situation to an extent where we might have avoided a lot of hypotensive states. So I think this is great. So training and a wide echo to this should be fully available, in particular at places where landing of this kind of patients is routine. So
I think you made that excellent point in your presentation as well, Dr. Della Bella, that management of VT storm is very much a team game. It's not just electrophysiologists who are dealing with just the ablation aspect, but everybody, you know, the intensivists, the anesthetists, the surgeons, if you're going to use mechanical circulatory support and para device, etc., you need interventionists. So it's very much all hands on deck. And sometimes it's so difficult to manage these patients that it's good to be able to think outside the box, as it were, and bring about a different approach to management of these patients. So I totally agree with you that this technique needs to be a bit used more widespread, but obviously we have to ensure that the correct training is delivered. So thanks very much to Dr. Enrico Baldi as well for offering the training package that you do. I'm sure many of our readers will find that very, very useful. I'm mindful of the time, and so I would love for this to continue for much longer, but I'm afraid we have to call it a day. So I'd like to thank all three of you speakers on behalf of the Arrhythmia Academy for giving up your time today and sharing your thoughts on not only this excellent technique, Dr. Savastano and Dr. Baldi, but also putting it in context, Professor Della Bella. It's been an absolute pleasure to spend this time with you. Thank you.
Okay.
Thank you.
Thank you for organizing this, and have a nice day, everybody. Bye.
Thank you so much.
Bye-bye.
Thank you very much. Bye-bye.
Bye.